I'm really grateful to be here, and before I turn it over to Tom and Roy and engage in some Q&A, I want to just share one brief story about a practical change in consumerism that we have experienced right now, and I know a lot of you have as well. But like many systems, we invested in a complete electronic medical record, clinical and revenue cycle system. In our case, it was Epic. And we decided that we were going to really leverage the MyChart activity to create greater patient engagement, greater patient empowerment, greater patient ownership. So we've been very, very active and aggressive in pushing that. You have a lot of wonderful lessons that come from that, and I wanted to share just real briefly a couple of ahas from our perspective. So I pulled randomly and took a look back at a few hundred patients pre-healthcare MyChart active engagement and post-active MyChart engagement. And it was really quite remarkable. The population that was very actively engaged in using the self-empowerment tool of MyChart had a 0.5% cancellation rate in the doctor's offices versus a 10% cancellation rate we were seeing in the general population, which was really quite remarkable. And it was because they were using technology like they do as consumers in every other aspect of their life. They were going online. They were looking at multiple choices for visit times and visit locations, and they owned that time. They owned that appointment, as opposed to a clinic receptionist telling them, we can see you 3 weeks from Thursday at 5 o'clock, will that be okay? And they say yes, but they really don't have an ownership in that. And if life gets in the way, they cancel or they don't show. 0.5 versus 10%. The other interesting thing that I saw is I looked at this population. They were twice as likely to call and scrutinize their bill and raise questions over whether they got the value in the high deductible contribution that they made. And so challenging things like, my deductible is $200 for this visit and I saw the physician for 5 minutes. That doesn't seem like a fair trade to me. So this engaged consumer, right or wrong, as they use the technology and the portals that we now have at our disposal, is going to really require us to think very, very differently. And I think the consumers in healthcare are going to adapt the same habits that they do as consumers in every other aspect of their lives. They're going to look for value, access, predictability, transparency. And if they do, here's the last piece of data. The population that was actively engaged in MyChart, we had the highest percentage of their share of care staying within our health system versus going elsewhere, because they also are loyal when that whole other value proposition is created. So I wanted to share that as a little bit of an integrator between the two concepts. So with that, we're gonna open it up to Q&A, and I'm gonna start with a provocative question, or at least I think it's provocative. And that's that, you know, both of you came at this from different angles as it relates to the potential impact that technology could have on the industry. And one question I have is, do we have an impending workforce shortage or not? Because there are all sorts of studies that are suggesting we've got a looming crisis with physicians. There's a proliferation of medical schools that have popped up all over the country. And yet really, Tom, looking at some of your slides and looking at where care can be delivered and by whom it could be delivered, one could say we're heading really down the wrong path.
Yeah, so it's a great question. Part of it's the timeline. So when you think about the rotation and you think how much of this might move to the home or might move to virtual or might be inclusive of social or wellness and what you need to do to take care of Fred, our view is that there's not going to be a shortage, that there's going to be massive labor rotation. So we picture the need for, you know, somewhere in the neighborhood of 2 million primary care practice extenders that are going to be involved in coaching and call center technology. And we see the rise of people be experts in biomarkers and social coaching. I actually think in the core physician groups, which are highlighted as the primary shortage area, I actually think we're going to be in good shape.
Yeah, I would totally agree. And actually, there's a talk I've given a couple of times on the challenges we're going to have to deal with in the new model. And actually, one of the challenges I talk about is provider disenfranchisement. When I was So actually, I think it's just the opposite. I don't think we're going to have a workforce shortage. I think we're going to have some disenfranchised providers. And I think it's no different from any other industry dating back to the time of the Luddites. if you know about the spinning wheel incident in the street out in front of the sewing shop, where the employees, when they begin to be replaced by other delivery mechanisms or technologies, aren't unhappy. Helped create the Walgreens Scott and White ACO when I was there, and I can remember the first discussion with one of the primary care leaders in the health system. This is 5 or 6 years ago. I said, "Yeah, we're gonna take all the patients that are being seen in ambulatory care. We're gonna segment them. We're gonna risk stratify them, and we're gonna try to take that bottom 2/3 out of the clinic and use other methodologies." And he goes, "Well, what am I gonna do?" I'm like, "Well, you're gonna be able to practice medicine, and not have people waiting 5 hours to be seen, sort of thing." So I couldn't agree with Tom more.
Great.
I think there's just a quick corollary. If you go inside of CareMore or Q-Liance or IORA, what you'll find is the physicians that are taking care of the Freds in the top of the pyramid and then managing the overall population, job satisfaction is extraordinarily high.
I think it's true.
The physicians feel very empowered.
Questions from the audience?
I'm just curious about the evolution of the medical record in all of this, which seems like there's a power struggle in terms of who owns it.
Yeah, so an interesting question. I was just at another institution. I was just moderating a panel session at this organization called Net Impact, which is students. About 60,000 MBA students belong to this organization called Net Impact, and we were talking about big data in healthcare. And actually, one of the questions asked the panelists is, who owns the medical record? And of course, I said, well, of course, the patient owns his or her data. Then I asked them, how easy is it to get that? And they said, oh, not very easy. And the kids in the audience were just like aghast. Well, what do you mean? I can't have access to my information all the time. And I said, yeah, so if you're seen in a hospital, and then it got into the whole discussion about how information is exchanged and the entire ecosystem of who has access to your information, which they were all shocked by. What do you mean, like, if I'm at Kaiser North and I go to Kaiser South, they don't have my record? Well, shouldn't I have it? So, well, yeah, it'd be interesting if you could. So I think you own it. I just think, that we're way behind in our understanding of how to share it with people, how to share it with each other. The platforms don't talk to one another. It's a problem.
I think over a 5-year horizon that the consumer is going to own it, and I actually think that the health records themselves, they have less than 5% of what they need to really understand Fred. And I think that, and it was a slide I didn't put up, but I think players like Google and Amazon, they already know vastly more about your patients than you do. And I think the notion that delivery systems will own their own portal or own their own health record is just not, it's a non-starter, because that's going to migrate out and the number of entry points to the system is going to explode, and it's going to get integrated at the consumer level.
We see a lot of companies at AVIA that are creating these sort of consumer managed platforms for healthcare information. And actually, to capitalize on one thing that Tom said, in this future where people are doing more things themselves, to me, that's an opportunity if I were creating a company, because we really need to collect all that data. Yeah. And we to make intelligent inferences and to make, to use analytics to its fullest potential, we can't only use the little pieces of data that are generated when they're seeing a provider, which will be less frequent in the future. So, there's going to have to be a lot of work done around how all that data gets collected, I think.
I'm sure you noticed WebMD acquired Avado, and Avado is a portable portal, a portable health record, and then Allscripts bought Jardog, and clearly these are designed for the consumer, for the record to travel with the consumer and aggregate the pieces across the setting.
A little bit of follow-up on that, on the question of data and how much of that is in the consumer's hands alone versus in the care team's hands. When I see Dr. Fields and he asks me how much I exercise, I usually take how much I exercise and multiply it times 2. And when he asks me how much alcohol I drink, I usually take the number and divide it by 2.
Yeah.
I'm a little comfortable with Dr. Fields having access to all kinds of data about what I buy at the grocery store, or how many visits I go to Total Wine, or, just, is that going to really work for consumers? They're going to want that full transparency to the care team.
Yeah, we can do a couple of shots at this. When I talked about Health Market 2.0, there are a lot of moving pieces. So let's assume that your care team's really partnering with you on your health and you're living in a more consumer-oriented market, and it's their job to help you live better, and you're actually, as the consumer, going to be able to risk arbitrage, so they're on your team. And I think the relationship between the consumer and the care team looks really different. So in the today world, you're going to want to insulate and protect your privacy. You may not want to share it with your provider, and you certainly don't want to share it with your payer, because you recognize that if you do, you're going to be priced against, and if you do it with your provider, you're going to be scored in an unfavorable way. But that's looking through the market in the today lens. As we flip over and consider delivery a health and wellness system designed for consumers, it's going to be about that partnership. And I see that as part of the change coming.
Yeah, I would say that it's the sort of question I would probably ask too, because we're probably of a similar vintage. I would say that people, my oldest daughter, that generation, are very much less concerned about this. You see it everywhere. They're very much less concerned about sharing their information, sharing their medical information, sharing their personal information. So I think that not only are the systems of care going to change and make it probably more feel more reasonable to do that, but I also think there's a cultural shift afloat already.
Yeah, I was worried you were going to ask about low-cost sequencing, because I think with Illumina and 23andMe, we're going to be asking that question again, but it's going to be way harder to answer.
Thank you both. This was excellent stuff to see, especially as a millennial. To your point about data, it's just a given. I think Edward Snowden taught us that too, that my generation sort of has a different perspective, and we track whatever European studies say is the amount of wine we should consume, which seems to keep going up, so that's always good. But what I'm curious about—
I track that too.
When we look at disruptors, the poster child is Uber. Sadly, Uber is also the poster child for crisis management this week for some things they did in terms of data and snooping. But what they were able to do is just ignore existing and archaic regulations and go their own way. And now the regulations are catching up. So I didn't see either of you speak to this, but federal government and state governments play a huge role in healthcare delivery. So where are regulations going, and how will they be disrupted in this new world?
I had to bring that up. Yeah. Well, it's a very, I think it's a real erudite question, actually, because a lot of what I certainly talked about and some of the things that Tom talked about are going to require regulatory concomitants. I mean, for example, if you're doing a test at home that's got a dichotomous yes or no answer, and the treatment is relatively safe, and you agree to bear the risk of the treatment, why do you need to go through a physician? But from a regulatory standpoint, that's practicing medicine. I was on the state medical board in Texas for a while, and if you did that, and we would try to put you in jail, for example. So I do think there's going to have to be a lot of regulatory work done as well over time to catch up to some of these things we're talking about.
Yeah, I don't have a great answer to it. I'll tell you there are parts of the market that are more open. So the company that Roy profiled called Livongo, they went through FDA approval on their Wi-Fi blood glucometer. It took about a year, but it was a relatively supportive process, and there really are no barriers now for consumer adoption of that technology. So I think there's going to be spaces in the market where we have a clear path forward. So Walgreens doing a health spot. I think the Bain Capital team that originally built the MinuteClinic, they were very, very wise about how they actually set the diagnostic codes that were in scope for a non-physician practitioner. And I think the capital markets will be savvy about how to pioneer the space outside of the regulatory guidelines. But the big changes, power of the physician license, delegation of capital through CMS, and risk in the Medicare world, they're going to require regulatory force. And so we'll see how that plays out.
One of the great things we have on our side, I think, is the cost structure of the existing system. That's going to play in favor of regulatory change over time.
I want to just switch gears for a quick moment and ask Tom, and then of course Roy, your comments as well. Tom, you started off your presentation by saying it was almost like you wanted to calm the audience down before you took us on a journey, and you said hospitals are still going to be important. Yeah. But then you proceeded to describe Health Market 2.0, which, if really is fully embraced, would suggest that the amount of capacity this country will need for hospitals is significantly smaller than what it is now. And at $1 million a bed, which is the average construction cost, total cost, and we continue to build and rebuild new bed towers, what do you think that capacity really is going to look like?
Yeah, so if you pick up the P2C paper, the patient to consumer, we do make comments on that, and I know it's really hard to project, but we're of the mindset that over a decade horizon, we're gonna need probably 60% of the capacity that we have. And I think there's a lot of opportunity for our health system to continue to get much better at acute and complex care, and I think that's going to be moving forward. But when you look at the dynamics of low-cost sequencing and FRED, the opportunity to catch it earlier and treat it in a non-hospital setting and having it move to outpatient and ultimately to the home is really high.
Yeah, George Isham, Health Partners. Thank you very much for those terrific presentations. I have a variant on the question of the millennial at the other side of the room there. Does this consumer revolution penetrate Medicaid, Medicare, and if so, how?
Yeah, I would say on Medicare, with Medicare Advantage, it already has. And I think I think MA is one of our poster child marketplaces for companies like CareMore that have built the model and built the MA plan and actually compete on price. And I think the structure of Medicare Advantage actually allowing the provider of the care to reinvest in zero deductible plans and enrich benefits and really live at that level is actually really good for the consumer. And I think it will also play forward in Medicaid. I think we're going to have competition between more integrated value-based models and narrow networks. And I was teasing the audience a little bit by saying I'm waiting for you to invent it. But the notion that Medicaid in a consumer world looks like a skinny network with low unit pricing is not very creative. And the notion that we'll reinvent that in a way that we can deliver much more for less dollars in a consumer choice environment through engagement, I think is actually really promising.
I don't think we have any choice. I think it has to involve Medicaid. I mean, especially when you think about the group, the dual eligible group and so forth, I mean, and again, the cost structure around those patients, it has to involve those groups. And we actually, I think, are going to have to incentivize health systems and providers and payers to pay attention to those groups when they're deploying new technologies.
Christy Lamack from University of Alabama at Birmingham. You both mentioned leadership as one of the key drivers. And if a board that's getting ready to hire a leader pulled you aside and said, how do I know it when I see it? I mean, what are those competencies, skills, experiences that the leaders of 2.0 or of this new model, what are those things? And how can you help us as educators develop that and as organizations build it in our workforce or hire for it?
Yeah, so there's been a number of studies that have been done outside of healthcare looking at the correlation between leadership behaviors and success around innovation. It's fairly uniformly agreed to by these various organizations that have studied this that there's some common characteristics, that the leader has to actually be involved personally in innovation efforts. The leader has to commit financial resources to leadership efforts. The leader has to create organizing structures so that innovation can take place when he or she is not around. And so the appropriate other individuals and committees and structures and so forth. And the difference in success, financial success in companies that have adopted those sorts of, or leaders that have exhibited those sorts of behaviors versus those that don't is actually relatively remarkable. Capgemini's done a study on it. Boston Consulting Group's done a study on it. You guys may have studied it, but and so I would say those are at a minimum in regards to the sorts of behaviors. I don't know if there are any character or characteristics I could suggest that might work, because I think that would be a little false, but certainly those behaviors would be what I'd be looking for.
Yeah, great comments. I would add to that, and we put a number of these in the big fold-out that went out, but at a competency level, being a highly aspirational leader, definitely walking the talk and having continuous commitment, demonstrable commitment. But at the competency level, the IT, the partnership, the home care, the retail, the consumer, whoever steps into a large health system, even if they're very progressive by today's terms, the 10-year view, if that health system really plans to evolve into consumer health and wellness beyond population health, it'll be a very, very different business. And so being able to open up the culture so that the culture is accepting of new talent and actually shifting what the cultural norms are really a requirement of the leader. And I'm not sure it happens in one leader's turn. It may be that it could be 2 turns before you make that happen.
And I would add one thing from my perspective,
Yeah,
and
you're
that's
great.
that a leader has a fundamental belief that radical change does not have to exclusively come from the outside in, but can also come from the inside out. So thank you all so much, and please join me in thanking Tom and Roy.